Hello viewers, and welcome once again to Healthy Wrinkles, a channel devoted for better healthcare of senior citizens and geriatrics. Today we have once again Dr. Prem. He's a leading geriatric expert from Jaslok Hospital, Mumbai, and we are going to talk to him today on the subject of ADL, activities of daily living, and IADL, which are used as a geriatric assessment tools. So director doctor, jumping into the question, my first question is, what is ADL and IADL, and what is the significance of those tools?
Yeah, thank you, Mr. Sherry, for having me again. So the thing is, quality of life matters a lot. Independence matters a lot as far as older adults are concerned. So that's why I think ADL, which is activities of daily living, matter, and IADLs also. So ADLs are just the basic things we do in everyday life. That is bathing, dressing, toileting, then transferring, mobility, that is from one place to another, and whether we are able to do that all on our own, which includes bowel, bladder, everything, taking care of yourself, cleanliness, dressing up, grooming. So a lot of times people are not able to do it. So that's why the ADLs, when the activities of daily living get affected, then we get an indication that that older adult is going towards dependence. Now, another thing is IADL, which is instrumental activities of daily living. Those are the activities which are needed for anybody to maintain an individual household, which includes managing finances, cooking, transport, ordering groceries, then paying your bills, then also trying to take your own medicines, in which a lot of people cannot take. So if a person is independent in their ADLs, means they're okay, and IADLs, if they're not independent, then of course they will need help for that. So self dependency is there, but if a person is not independent in their ADLs, so that means they're totally dependent. So for example, if they are not able to bath, they are not able to be doing their mobility on their own, grooming on their own, then they are totally dependent. So that obviously shows us the current scenario of that particular older adult, and the fact that they will need caregiver. So that's why ADL and IADL are very important. A lot of people can do the ADLs but cannot do the ideals, so that they can be helped. Like a lot of people in the COVID times have been helped in that only. They're independent, but they are not able to get their food. They're not able, so they have been helped to do the ideals and maintain the household. If a person cannot do the ideals, then there is no use of seeing the ideals, because if they are not able to take care of themselves, means they will not be able to take care of the household. So that is the significance, but it shows us where the older adult is going. Is basically, if the ADL dependency is become more and more dependent, then that means the older adult is more maybe bedridden or will need more help. So that's why ADL IDL is very important.
So doctor, my next question is in the clinical setup, like, you administer this questionnaire through a conversation with you, or patient's relative, and or patient himself or herself, or how actually you administer this?
Yeah, usually it's done through various scales. So we basically do it ourselves. If the person cannot speak, or if the person is not available, then we can do a proxy with the relative as well. So it is something known as Barthel's ADLs, and CATS ADL and IADL. So these are the ones. Lawton. These are the various scales which are sort of used, and this is how we sort of do it. So it can be a proxy event also, but usually if the patient is there, then that gives us a better sort of knowing, and then we score it. So basically it's having bowel, bladder, grooming, toilet use, feeding, transfer, mobility, dressing, bathing. So when we score it, and then we see basically if the person is dependent, then the score obviously will be lesser. If the person is independent, then the score will be more. So then we obviously, so the more the score, the better it is. The lesser the score, the more dependent the person.
And doctor, just like other diagnostic parameters, like for example, say diabetes or cholesterol, I know you tend to monitor them maybe at certain frequency, maybe it could be once in a quarter, once in a year, or whatever recommended by the medical practitioner. So these kind of tools are also you recommending to be administered, say at certain intervals repeatedly, and then see the trend of that individual, or how do you use it?
See, this is a part of the GA, that is a geriatric assessment anyway. So when we do a basic geriatric assessment for the first time, we will know. So we know a baseline. So anything which is going away from that, we realize. So we usually repeat it or maybe on follow-up once, depending upon the chronic conditions. For example, if a person has had a stroke, then obviously the ADLs and IDLs will be going. If a person is post-op, then that will be going. But these are temporary. That's why doing them again is okay. If a person is going to recover out of and becomes independent again, that's why we shouldn't just keep it to once. Once is a baseline where we see the person. There might be an improvement also, because there are only acute things which might be going bad. Like for example, there's a hip fracture, post-op, the person recovers and back to the earlier, at least able to do the ADLs. IDLs maybe not for some time, and because a lot of people unfortunately who have hip fractures are living alone. So basically they have been taking care of themselves alone, but that fracture just puts them entirely onto the dependency part. So yes, it needs to be repeated. I would say more on your clinical acumen when you follow up, and then depending upon the chronic conditions, comorbidities. That's why a lot of things matter. For example, if a person is diabetic and has severe neuropathy, then automatically the walking will be sort of affected. So we need to see, are there any correctables? For example, if a person has got paraplegia and is not going to recover, then we know that the ADL is going to be like that. So we might, even if we try to repeat it, we are more importantly knowing, for example, if that is paraplegia in which a person can still eat themselves, that is a different story. But if it is involving the sort of having dysphagia also, not able to eat, there is a Ryle's tube, then everything becomes different. So case to case basis, but very important to have a baseline, because what are you judging from that saying that the person has become dependent, if you don't have any idea when the person was dependent at all? If somebody is already bedridden and you do that, then, and you are knowing the conditions, there might not be a magical improvement. So that is something which as doctors and as caretakers we need to know. More than anything, it's important for the caregivers to know also, for their expectations, how much improvement will be there, and also the fact that a professional caregiver must be needed. So imagine a person who's got a hemiplegia, stroke, chronic, and who is not recovered through that. Even with physiotherapy, maybe there are contractures. So taking care of that particular person on their own will be very difficult. So that is something which has to be always kept in mind, to help the caregiver also to take help from the outside professionals, because not everything they can do.
Right. And doctor, you mentioned some examples already, but what are the typical interventions you would undertake depending upon the scores? Like, so as once you said, it could be medication, it could be, suggesting that some help is now required on a day-to-day basis, or what else as interventions are outcome of this geriatric assessment?
So usually when we do a functional assessment, it is very important in a lot of things. It can be also important in treatment protocols also. For example, if this particular person has a poor function already and it's got multiple comorbidities and also diagnosed with a cancer, then that might also maybe make our judgment whether how much quality of life we are going to improve. Ultimately, goals of care are important. So if you talk about interventions, it is very individualized based. For example, if there is something recoverable, if there is a periarthritis shoulder, which is known as frozen shoulder, we still know that if we give physiotherapy and we can improve it to a certain extent, so the quality of life will improve. Whereas if it is actually something, for example, if a person has had you can say an accident in which the spine is permanently damaged and there is no sort of chance of recovery lower for both the lower limbs, then we obviously have to be very, very careful in our goals of care. So for involving the individualized, you can say, partners in our care, that is the physiotherapist if needed, then the occupational therapist, a lot of times they are also involved, then the podiatrist, especially for giving the proper footwear, because all these things are very, very important. Small things which affect the quality of life to a lot of extent. So a prognosis of a particular treatment of a particular condition is also dependent upon the functional part of the older person, which becomes very significant. When it's a younger person, we do not consider that always, because we see only maybe the condition per se. But with age, already age related, a bit of degeneration, all the organs happen. So on top of that, when there is an insult, that's why this functionality is important. So I would say, to put it in a nutshell, the more the person is away from the bed, the more happy I am. The more mobile the person is, the more happy I am. The more towards the bed, more immobile, I would be a bit more concerned, because everything tends to go downhill from that.
Thank you, doctor, for nicely, articulating and also giving the right examples. about how these assessment tools, ADL and IADL, are used. So thanks once again for appearing on Healthy Wrinkles. Thank you.
Yeah, thank you. Thanks a lot.